Hello all, welcome to Medical ABC. Today we'll be talking about the inflammations of cornea, which is known as keratitis. So the inflammation of any part of the body will have a term, will have a word, will have a suffix, which is known as itis. In the case of cornea, we'll call it as keratitis. In this video, we'll be talking only about the bacterial corneal ulcer, as that itself is a very important topic for medicos. The other corneal ulcers will be dealt in a separate video. Before we get into the topic of bacterial corneal ulcer, let me tell you the main three features of keratitis, that is inflammation of cornea. So it's nothing but edema, infiltration and congestion of the corneas. Corneal edema, cellular infiltration and ciliary congestion. So these three features you can find in any other inflammation as well. Yes. So what is ulcerative keratitis? So keratitis can also can be accompanied with an ulcer or may not be accompanied with an ulcer. If it is accompanied by an ulcer, we'll call it as ulcerative keratitis, and if it is not accompanied by an ulcer, it will call it as non-ulcerative keratitis. So ulcerative keratitis is nothing but loss of epithelium accompanied by inflammation in the surrounding cornea. That is, we are putting the definitions of ulcer and keratitis together to get the definition of ulcerative keratitis. So the ulcer, we know it is nothing but loss of epithelium, and keratitis is nothing but inflammation of the cornea. So together, we'll get the definition of ulcerative keratitis. To be precisely said, it is discontinuation in normal epithelial surface of cornea with necrosis of surrounding corneal tissue. Here I have provided an animated picture as the ulcers, the bacterial ulcers mainly, differs according to the agent and according to the host. So here is the animated picture. Here you can see it is visible as grayish discoloration often. So the ulcer will be often visible as grayish discoloration. So now we'll see the classification of corneal ulcers. The corneal ulcers can be classified on the basis of etiology, that is what causes it, or on the basis of location, like where the ulcer is present on the cornea. Sometimes it will be present in the center of the cornea, sometimes it will be present in the periphery part of the cornea. So according to the base of the location and according to the involvement of layers. So cornea has 6 layers. Sometimes the ulcer will be present only in the superficial part. Sometimes it will go deep into the 6th layer itself. So on the basis of the involvement of layers also it can be classified. In this video we'll be talking about the etiological classification. That is this. So etiological classification again, it can be due to a trauma. The ulcer can be due to a trauma. It can be due to an infection, which can be a bacterial infection, a viral, a fungal, or a parasitic infection. It can also be immunologically mediated. In this video, like I told you before, we're only dealing with bacterial corneal ulcers. So the bacterial corneal ulcers will have the following symptoms and the following signs. Symptoms are nothing but what the patient says to the doctor, what the patient complains to the doctor. So it's nothing but photophobia. The patient cannot look at the light, cannot look at the direct sunlight or any light. The lacrimation. The patient will have complaints of excessive tears running out of his eyes. The congestion, which is causing redness in his eyes, pain and reduced vision. He'll complain of blurring of vision. Signs are nothing but what the doctor elicits from what the patient have already told. So signs are nothing but what the doctor says, what the doctor finds. So the doctor will find there is swelling of lid, blepharospasm and conjunctival hyperemia. On a whole, the bacterial corneal ulcer will have the following features. We'll see what it is. The ulcer will be yellowish white in color most often, and it will be oval or irregular. Depends upon the organism which is caused. It depends upon the bacterium, specific bacterium which causes it. It could be either oval or irregular in shape. The margins of the ulcer will be swollen and overhanging, and the floor will have necrotic material. So even if you don't know a bacterium in specific, you can write all these points for bacterial corneal ulcers. So now you might have a doubt that can anyone get a corneal ulcer? Can I get a corneal ulcer? Okay, the answer is not everyone gets corneal ulcer, as there are defense mechanisms present in the tears. So what people are mostly prone to corneal ulcers? Infective corneal ulcers. So the infective corneal ulcers develops only when the defense mechanism is destroyed in the person, or if there is an existing ocular disease in the person, or if the person is very weak, his immunity is very weak, or if the agent causing the disease is virulent. So these are the chances, these are the risk factors, or these are the areas where you can find an infective corneal ulcer. So now the risk factors, so the predisposing factors which causes infective corneal ulcer. So the organism enter mainly during a trauma. And the people who have dry eye have more chances of getting corneal ulcer than other people. The prolonged steroid use can cause corneal ulcers. So why steroids are contraindicated in corneal ulcers? then contact lens wearers have more chance of getting corneal ulcers than the other people. Poor local hygiene and previous infections of the eye. So these are also the risk factors for causing a corneal ulcer. We are going into one by one bacterium. So the first is Streptococcus pneumoniae, pneumococcus. This bacterium is mainly linked to Hypopyon corneal ulcer. So Hypopyon, I'll tell you what that medical condition is in the next slide of the same video. Before knowing about what a Hypopyon is, you also have to know that Hypopyon, this condition, is mainly linked. Hypopyon corneal ulcer, this term is mainly linked to this bacterium. There are other bacteria also which can cause Hypopyon, but Hypopyon corneal ulcer, this term, is mainly linked to Streptococcus pneumoniae, that is pneumococcus. Again, I'm telling you there are other bacteria which can cause Hypopyon, but if there is a multiple choice question asking which organism is linked to Hypopyon corneal ulcer, the answer is always pneumococcus. And talking about the ulcer of the pneumonia, that is S. pneumoniae, the ulcer will spread over the cornea in a snake-like pattern. So it is known as ulcer serpens or creeping corneal ulcer. Unlike other ulcers which do not have this kind of name, Streptococcus pneumoniae have a specific name because this ulcer will creep over the cornea in a snake-like pattern. So this ulcer is called as ulcer serpens or creeping corneal ulcer. And the source of infection of this pneumococcus is mostly following chronic dacryous status. So now I'll tell you what is a Hypopyon. So Hypopyon is a medical condition involving inflammatory cells in the anterior chamber of the eye. It is an exudate rich in white blood cells seen in the anterior chamber, usually accompanied by redness of conjunctiva and the underlying sclera. So you can see this white thing here is nothing but Hypopyon, and here it is accompanied by redness of conjunctiva. So what really is Hypopyon? I'll tell you. In the case of S. pneumoniae, what happens is that the bacterium, while causing an ulcer, will release toxins. So just like any other organism which releases its own toxins as a mechanism of its virulence, the S. pneumonia also release certain toxins while producing an ulcer. So these toxins will be absorbed from the ulcer. So these toxins produced by the bacteria will be absorbed, and that absorption of these toxins will cause iritis, some degree of iritis, that is inflammation of iris. This inflammation is, the inflammation is accompanied by infiltration of cells. So since there is inflammation here, that is iritis, that is inflammation of iris here, there is exudation of leukocytes, that is WBCs, from the circulation, that is from the vasculature into the anterior chamber of the eye. So when these cells come as a result of these toxins produced by the bacteria, what happens is it gets deposited as such in the bottom portion of the eye, in the anterior chamber. So this cells getting deposited, the white blood cells getting deposited, is nothing but Hypopyon in this case of S. pneumoniae. There are other Hypopyons of other bacteria which also contain stuffs in the Hypopyon other than the white blood cells, which also includes bacterium. But in the case of S. pneumonia, you have to remember this Hypopyon only have cells in it, that is WBCs in it, and these WBCs have come into the anterior chamber as a result of toxins. So the bacterium is not present in this Hypopyon, only the WBCs are deposited in this Hypopyon, and that too as a result of bacterial toxins and not the bacterium itself. So the bacterium is not present here, only the cells are present here. So why the Hypopyon of S. pneumonia is known as sterile Hypopyon. Another MCQ, Hypopyon of S. pneumonia is a sterile Hypopyon because it does not have bacteria in the Hypopyon, it only has white blood cells, that is leukocytes in the Hypopyon. The pus only has WBCs in the Hypopyon. So this Hypopyon of S. pneumonia is sterile Hypopyon. So iritis, diffusion of toxins, outpouring of leukocytes to bottom of anterior chamber, Hypopyon. So diffusion of toxins, only inflammatory cells are present in the pus and not the bacteria. So bacteria is not present, so it is known as a sterile Hypopyon in the case of S. pneumonia. So I am reminding you again, the Hypopyon of S. pneumonia is a sterile Hypopyon. Now talking about the features of the ulcer serpens, that is the ulcer of S. pneumoniae. The ulcer of ulcer serpens is greyish white ulcer or a yellowish ulcer, and the ulcer is disc shaped. Though the ulcer spreads in a snake-like pattern, the shape of the ulcer is a disc shaped ulcer, and it is present near the center of the cornea. Location of the ulcer is near the center of the cornea, and this spreads in serpiginous pattern, already told you, and it is associated with violent iridocyclitis. Iridocyclitis is nothing but inflammation of iris and ciliary body, which I have told you in the hypopyon topic. And the hypopyon increases in size rapidly, often causing secondary glaucoma. So the hypopyon, if it is increased in size, sometimes it may also lead to secondary glaucoma, a complication. And there are high chances of perforation in the cases of ulcer serpens. So the ulcer serpens is not a superficial ulcer. From this point, you can understand it. It might also invade the deeper layers, causing perforation. So next, this is a diagrammatic representation of how the hypopyon looks in the anterior chamber, the bottom of the anterior chamber. And this thing here is the cornea, and here is a creeping pattern of the ulcer serpens. And I'll try to draw this yellow thing I'm drawing here. You can also draw, you can also draw this thing for easy understanding that, this is creeping pattern of the ulcer serpens, while this is that is the hypopyon in the bottom of the anterior chamber. So next we are going to the second bacterium, which is nothing but Pseudomonas. Before going into the things which have been written on the slide, let me tell you one thing. Pseudomonas is a bacterium mostly associated with contact lens wearers. So the people who are wearing contact lenses, not everyone, the people who do not really take care of using their contact lenses, those people have more chances of getting Pseudomonas bacterial corneal ulcers. Also, the Pseudomonas bacterium will cause a rapidly spreading corneal ulcer and rapidly perforating corneal ulcer. There are other bacterium like S. pneumonia, which have been told you earlier, that it also causes perforations. But the bacterium which mostly causes the perforation, rapidly perforating corneal ulcer, was mainly caused by Pseudomonas. So rapidly spreading as well as rapidly perforating corneal ulcer is aided to Pseudomonas. Not that there are bacteria which not causes corneal ulcers, which do not spread or which do not perforate. There are other bacteria also which spreads, which also perforates. But Pseudomonas is linked to rapidly spreading and rapidly perforating corneal ulcers. And Pseudomonas also associated with hypopyon. Again, I told you, S. pneumonia is not the bacterium which only causes the hypopyon. There are other bacteria as well. So here is another example for you, Pseudomonas, which also causes hypopyon. And the ulcer of the Pseudomonas is irregular shaped ulcer and is a sharp ulcer with thick greenish mucopurulent discharge. So it's irregular, so you can imagine the margins of it will obviously be sharp. So irregular sharp ulcer with thick greenish mucopurulent discharge. And you know the corneal ulcer will have necrosis surrounding it. And the necrosis in the case of Pseudomonas ulcer is liquefactive necrosis. And around the cornea there will also be a biofilm, that is a ground glass, that is semi-opacity. The next bacterium is S. aureus, Staphylococcus aureus. So the ulcer caused by Staphylococcus aureus is an oval ulcer, and it's a densely opaque ulcer, and the ulcer is surrounded by a clear cornea. So this is an oval ulcer surrounded by a clear cornea. And the S. aureus ulcer will mostly be a peripheral ulcer. Next is enterobacteria like E. coli, Proteus, and Klebsiella species. So these species, that is E. coli, Proteus, Klebsiella, these species causes only shallow ulcer, that it does not invade the deeper layers. It only involves a superficial layer, so it's only a shallow ulcer. And this ulcer caused by these bacterium is because of the endotoxin. So the toxins released by this bacteria, that is E. coli, Proteus, Klebsiella, will produce a ring-shaped ulcer, seen in the image here. Yeah, ring-shaped ulcer. Next is the pathogenesis of corneal ulcer. So we have finished like the main bacterium which causes a corneal ulcer and its main features. So now we have come to the pathogenesis of corneal ulcer, which includes 1, 2, 3, 3 stages. In some textbooks you might find 4 stages. It is because that the active ulceration they might have taken it into a separate stage. So here I have taken it into one stage together. So it's only 3 stages in this. So first stage is stage of progressive infiltration and active ulceration. Second is stage of regression, and third is stage of cicatrization. First we will see stage of progressive infiltration and active ulceration. So in the first stage, what happens is, so look at this line. Yeah, this we just imagine that to be a normal epithelial surface. So if the normal epithelial surface is damaged or if it is invaded by an organism, in this case we are talking about bacterium, so just imagine if this epithelium is invaded by a bacterium. Yeah, so if this portion, the center portion of this epithelium is invaded by the bacterium, what happens? It is damaged. The tissue there will be damaged and that tissue will come off. When it comes off, it leaves the discontinuity and that portion causing an ulcer. So this is how an ulcer is normally formed. What happens in this first stage, that progressive stage, is that infiltration of leukocytes into corneal epithelium from circulation, that is vasculature, to the site of damage. So whenever there is damage, that is, I've told you in this thing that epithelium, this portion is attacked by a bacterium. Supposedly, if this portion is attacked by a bacterium. So whenever there is invasion by an outsider, by a foreign body, there will be infiltration of leukocytes. As a result of inflammation, there will be infiltration of cells, that is infiltration of leukocytes. So the leukocytes will come at this portion, and later what happens is sequestrum cast off, that is the damaged portion will go off, will come off. So whenever that comes off, again what happens? The ulcer, that is, there is discontinuity, that is ulcer formation there. So these cells which have already come there, that is infiltration of leukocytes, the cells which have already come there will surround this ulcer, just like this. Just like this, yeah. Surround this ulcer. So that's how it, so just a diagrammatic representation, don't take it seriously. Of course, I know you won't take it seriously. So this first stage, there is infiltration of leukocytes, and the damaged area will come off, leaving an ulcer, and the ulcer is surrounded by obviously the leukocytes which have already come there. So that happens in the first stage. Second stage, which is regressive stage, you can see the leukocytes is already surrounding the, here the leukocytes, oh, I don't know where it gone. Yeah, so the leukocytes are already surrounding the ulcer. In the second stage, what happens is the leukocytes already surrounding the ulcer will phagocytose the organisms and necrotic debris. Remember me telling you that the floor of the ulcer will have necrotic debris? Yes. That debris and that dead cells and that dead remains which is present in the base of the ulcer will be phagocytosed by the leukocytes. So leukocytes are not just idle there, they have a purpose. So they will phagocytose this necrotic debris present there. And that will result in appearance of the ulcer looking larger. So the ulcer is not actually larger, but it will appear larger because the things which have been present there have been phagocytosed by the leukocytes. I'll tell you how it look like. So if this is the ulcer, this yellow thing I have drawn here is the necrotic debris on the base, on the floor of the ulcer. So whenever there is phagocytosis of these yellow thing, that is the necrotic debris by the leukocytes, it is gone. It is entirely gone from the area. So the ulcer is appearing larger. Though it is of the same size, it will appear larger because the things which have been occupying the space have been cleared off by the leukocytes. And this is how the phagocytosis happens, you know it. Yeah. So this results in the ulcer appearing larger, and the ulcer gradually begins to heal, and the epithelium starts to regenerate at the edges. So at the end of the stage, at the end of the second stage, that is regressive stage, the ulcer will start to heal. And by the third stage, cicatrization, that is nothing but a term which is associated with wound healing. What happens is epithelium continues to grow. You know, the epithelium, the first layer of the cornea, has a capacity to regenerate. So that epithelium will continue to grow, and the fibrous tissue is laid down by fibroblasts and endothelium of the new vessels. You know, like any procedure happening in a wound healing. And then there is stroma, which thickens and pushes the epithelial surface anteriorly. So this is how the third stage also continues, and that's how the ulcer will gradually heal. So what if the ulcer is superficial? So we have talked about the stages through which the ulcer passes through. Now we have to also know what if the ulcer is superficial and what if the ulcer is deep. If the ulcer is very superficial, involving only the first layer, which is the epithelium, there is no opacity, there is no complication, there is no scar formation, because the epithelium regenerates on its own. While if it involves a Bowman, that is the second layer of cornea, and if it involves a part of the stroma, which is the third layer of stroma, there is a scar formation. That is, a scar will be formed as a result of healing. So healing is by scar formation if it is involving the other layers. So that scar is named as nebula. While if the ulcer involves a 1/3 of the stroma, there will be scar known as macula, and if it involves more than 1/3 of the stroma, there will be scar named leukoma. So if it involves 1/3 and more of the stroma, that is the scar formed as a result of that will be known as macula and leukoma respectively. So the scar names you have to remember. The superficial most part, that is, if the epithelium is only involved, there is no scar formation because there is no need of a scar formation in the healing, as the epithelium can regenerate. While in the other cases, if the deeper layers, like from the second layer onwards, if it is involved, there is a need of scar formation to heal. Just like any other body part, there is a scar formation, and that scar will be named nebula, macula and leukoma respectively. Next is about the management of corneal ulcer. Before I get into the management of corneal ulcer, let me tell you that corneal ulcers are nothing to be left very easily, very simply, because corneal ulcers can lead to vision-threatening complications. So whenever a patient comes to you with complaints of a corneal ulcer, you have to treat the patient before knowing which organism caused the ulcer. Like specifically which organism caused the ulcer, you have to start the treatment because it's a vision-threatening disease. So management of corneal ulcer include clinical examination, laboratory investigations and treatment. Clinical examination include history taking, physical examination and ocular examination. The ocular examination is by staining the corneal ulcer. So we cannot just see the ulcer as such because it is present in the cornea, very minute part of the eye. So we have to stain the ulcer using any of the two dyes which is available, which are either fluorescent dye which stains the floor of the ulcer, or rose bengal dye which will stain the margins of the ulcer. Next is the laboratory investigations. Since we are talking only about the bacterial corneals in the video, I've only focused on that topic. So the laboratory investigations include Gram stain and Gemsa stain smears, and the results will take time for it to come out. So we have to start the treatment before it comes out. The treatment, before the results of the culture are made, the treatment has to be started. So you might be asking me, like, how can you start a treatment? How can you prescribe a drug without knowing which organism caused the ulcer? It is very simple. As in the case of bacteria, we have to give drugs which cover on both the gram-positive as well as gram-negative bacteria. So we are giving a combination of two drugs in both the options we have focused here. The first one is fortified cefazolin and fortified tobramycin, combination of two drugs. And next is fortified vancomycin and any fluoroquinolone which is commercially available. So both these options, any one the doctor can prescribe to the patient according to his needs. Both the options, you can see it's a combination and it's not a monotherapy. Fortified means nothing but concentrated, very concentrated medication it is. And next, according to the symptoms of the patient, doctor can also help him get easy recovery. That's by prescribing dark goggles if he has any photophobia, and cycloplegic drugs like atropine to reduce the pain caused by the ulcer, and vitamins like vitamin A, B or C for the early healing of ulcer. So these are some other general measures that he can prescribe to the patients other than the drugs he have already prescribed. So thank you for watching Medical ABC. Do like, share and subscribe for more.